Today we're going to talk about the May EMS training that we did. We covered pediatric respiratory illness. Specifically, we were talking about croup, RSV, bronchiolitis, asthma, epiglottitis. We talked about the ART. Eric and Cassie gave some updates on that, what they've been doing, what the process looks like. There's an email, so read the email, follow the process. We discussed specifically that there's a process between fire and police to get patients on the radar of ART, and so that process needs to be followed, right? So it's not a complicated process, but it needs to be done, specifically reaching out to police so that they can make a report so it gets funneled to the right place. So keep doing that. If there's good things that ART is doing, let them know. If there's things that can be adjusted, let them know. So again, read the email on that for some of those details. Specifically, today I want to talk about a tangent to the discussion we had about treating pediatric patients. We talked about, in some of the training days, we talked about using albuterol. Albuterol is a fairly low-risk medication, so I wanted to steer my discussion to lower risk and higher risk medications. And every time you're giving medications, you got to think about the risk-benefit ratio. So things on this side that we'll talk about are generally lower risk medications. Things over here, a little bit higher risk. Albuterol in particular. The side effects of albuterol are anxiety for some patients, tachycardia, making patients feel jittery, right? Is that a huge deal? Most of the time, no, right? Kids can handle albuterol pretty well. Kids can handle being tachycardic, especially if they have some respiratory illness and a fever. They're going to be tachycardic already. Can they handle more albuterol if it helps their breathing? Yes. It's a fairly low-risk medication for most patients, right? Most patients that get prescribed albuterol, whether it's nebulizers or inhalers, and on the prescription it has to say how often they can use it. Usually it's like Q2 hours or Q4 hours, right? It's interesting because patients will use that at home. They won't use it any extra, but then when they come to ER, what are we going to do? We're going to give them more, right? So on somebody who's really sick and say they're on BiPAP in the ER for asthma or COPD, we run continuous nebulizers, right? So the danger with patients at home using it too much is that they don't realize they're actually getting into a crisis situation. They're not getting better and they stay home too long. That's the biggest downside to that medicine at home in terms of using it too much, right? You can't really overdose on the albuterol if you're really that sick. So again, a fairly low risk medication. Steroids sort of fall in the same thing. We have in the protocol to use for asthma or COPD. If you think a patient is really sick and needs some and you give it and then it turns out it's more of a CHF picture, which we've talked about, they're looking with ultrasound, there's a way to distinguish that, but if a patient gets a single dose of steroids, not the end of the world. The same thing happens in the ER. Sometimes we'll give a patient, like their chest x-ray looks abnormal and they get a dose of antibiotics because it looks like maybe pneumonia. Maybe later they end up getting a chest CT for some other reason, and now the chest x-ray doesn't show pneumonia, it just shows atelectasis, which is sort of collapse of the lungs, right? And they get a dose of antibiotics, it's not the end of the world. So we don't throw medicine around willy-nilly, but if a patient gets a dose of something that turns out they maybe didn't quite need, it's often not the end of the world. So again, albuterol steroids, fairly low risk. On the other end of the spectrum, given cardiac meds, any medicine that's messing with your hemodynamics is a bigger deal. Adenosine, nitro, amiodarone, epi, all those things, atropine, right? Of those, I would say atropine is fairly low risk. I've never seen anybody get super tachycardic with a single dose of atropine. Sometimes it helps patients who are bradycardic, but even of the cardiac meds, again, those are sort of fall into different categories of atropine, fairly low risk. But anytime you're given that, keep those things in mind, that it can be a big deal. And we've talked about the concept that you don't have to fix a flying plane. And some of you are probably saying, yeah, we've heard you say that so many times, we're annoyed by it, and that's possible. But it still holds true. So if you have an old person who's really sick, but kind of holding their own, and you're close to an ER, and you're debating giving a cardiac medication, but you're not really sure about the rhythm or not sure if it's going to help, the blood pressure is holding all right, they're a little bit tachycardic. Is it AFib? Is it SVT? Is it something else? Is it just a weird rhythm? Is it hyperkalemia maybe? Like, what should you do? If you don't have to fix something, then don't. Right? If you're forced to act because the patient is super sick, then you act, right? So again, you're thinking about the risk benefits of those things. So same way with sick kids, we talked about the risk benefit. A kid with this was not this month, but previously we've talked about partial airway obstruction in a kid. They swallow something, they're choking on something. If you don't have to act on a partial airway obstruction, you probably shouldn't. If you're forced to act because it's now a full airway obstruction, that's a different thing. So you don't want to make a bad situation worse. When it comes to sedating medications, risperidone is on this end, ketamine is over here. Both have their appropriate use. Risperidone is pretty low risk. We talked about if you're giving risperidone and then signing a patient and they end up not going to the ER. I'm not losing sleep over that. Is that our standard practice? No. We generally transport patients that we're treating. But if you're giving somebody risperidone and then it turns out through the course of the conversation they feel okay, maybe they have a family member that's going to take them to the ER, they're going to follow up with primary care, they were able to chill out, not a huge deal, right? Ketamine on the other end of the spectrum, obviously a much bigger deal. Again, when we use it appropriately, that's perfectly fine, right? We use it when we have to, but much higher risk. Zofran, over here on the lower side. Again, giving patients Zofran, you show up on scene, somebody's nauseated, they get Zofran, and then they decide through the course, think, nope, I don't want to go, I feel better, right? We're not generally doing that. It's not standard practice to treat people and leave them, but not a huge deal. That's not a huge high-risk medication. But we'll come back to that, both of these medications when it comes to stacking the medications. Epi over here specifically for anaphylaxis, again, a big deal. Somebody who's really sick and has anaphylaxis, like a clear-cut anaphylaxis, like I'm allergic to nuts and I mistakenly just ate a peanut, then they probably, and they're having symptoms, they need epi, right? So there's no contraindications to giving that, but it's still, when you're giving it, it's a big deal. So keep that in mind. And then as it relates to, again, let's talk about stacking medications. I would say I put stacking any medications, not any medications, but specifically sedating and pain medicines. If you're stacking those, that becomes a bigger deal. It becomes a little bit higher risk. Like a single dose of whatever over here, Zofran, risperidone, not a huge deal. You have somebody that's got nausea, vomiting. Say you have a bad vomiting from a cancer patient and they've already had 12 milligrams of Zofran at home because that's what they've been prescribed. Giving more Zofran or giving droperidol or giving something else for the nausea, all of those medicines have an issue with prolonged QT. And I don't have the exact data on each one and what the risk of prolonged QT, but the easiest thing in my mind is to think that all of them do. Obviously, droperidol got a black box warning many years ago for that. Zofran has the same issue. Compazine, Reglan, Phenergan. In my head, when I think of the antipsychotics like Zyprexa, droperidol, the antiemetics, all of those, in my head, if I'm stacking lots of doses in a patient in the ER, this happened to me just a few weeks ago. Patient with severe nausea, couldn't get it under control. We're stacking these meds. Eventually, I probably checked an EKG to make sure that you're not causing prolonged QT syndrome. So, again, especially somebody who's vomiting a lot, maybe have electrolyte abnormalities because they've been vomiting so much, and they're taking lots of antiemetics. That's sort of a setup to have prolonged QT. Your potassium's may be low, your magnesium's low. Those things can be problematic. So, same with stacking pain medicine. A single dose of pain medicine for something, again, on the lower risk side of things, but you're stacking pain medicine because it's not getting under control, that can be problematic. In the ER, we see that with patients who say they have a dislocated hip or a shoulder, and we're going to do a procedure to put that back in, but we're having to give them a lot of pain medicine to keep them comfortable while we set up to do that. Once the sedation's done and we put the joint back in place, they still have those pain medicines on board, but now they don't have any painful stimuli from the joint because now it's reduced. So you end up with less respiratory drive because your catecholamines are better, your pain is reduced. Pain, again, is a good respiratory stimulant. So you take that away, and now that pain medicine is still on board. So that can be problematic. So anytime you're stacking meds, keep that in mind. All right, and then lastly, just talk about side effects are generally low risk. Allergies are high risk. So if you get nausea or some itching when you get pain medicine, we can fix that. Zofran can fix some nausea. We give Benadryl if you're itching. That's more likely to be a side effect. If it's a true allergy to a medicine, that's a bigger deal. So be aware of patients that have allergies to things, but again, side effects and allergies are not necessarily the same thing. And patients often say, well, I'm allergic to that. And you ask, it's like, well, I get some nausea when I get opioids. Again, that's a side effect. That's not an allergy. So that's all I got for this month. So thank you for your time.